Okay.
You can start whatever you want, Professor. Thank you.
Hello, and thank you for inviting me back, Carlos, to talk on artificial intelligence. The basis of this presentation is based on my research, which was shown here. My conflicts of interest are essentially that everything I do is related to hemodynamic monitoring, cardiovascular physiology, and using it to take care of patients, including in the bottom, my grants. What we're looking at when we look at trying to look at pattern recognition and defining featurization of those is we're trying to look at trends. And trending data is just a way of looking at time series data. This is an example of a picture of the night sky. I didn't change the night sky. It was just used with a regular time lapse. But if you look at the stars at night using exactly the same information you have normally, but look at it over time, emerging patterns arise, which were right in front of you, but you didn't see that. This is essentially what machine learning is doing. It is looking for patterns which are there, but are too subtle for you to see when you just take a quick look. Okay. Let me give you an example of some of our data in which we looked at this with Gilles Clermont and Fumi Agandelli. We had patients in the step-down unit who crashed, and that was shown here as a point in time in red. We had another group of patients who didn't crash, and we looked at various heart rate indices, and we walked backwards 6 days beforehand, and were able to identify features that were present in the unstable patients that weren't present in the stable patients. Then we went to a series of patients that were not used to create this algorithm, and we tested it on them, and we were able to clearly demonstrate that patients with a decrease in the heart rate variability separated out from those patients who would never crash, shown in blue, 2 days beforehand. This is important because variability is life. Lack of variability represents extreme stress, and I assure you, in the end of the day, there's nothing more stable than death. So you want to see variability. Importantly, however, it depends on what variables you look at, because since respiratory rate is often associated with spontaneous breathing rates or whatever you want it to be, we were not able to use respiratory rate variations to identify these unstable patients. When we think about the concept of using machine learning to look at time-space continuums, one of the easiest ways to look at it is just a single point in time. And we did that using an artificial neural net and created a fuse parameter, which we call the vital sign index. More interesting to me, at least, is to look at dynamic analyses that are done using more advanced machine learning approaches, such as principal component analysis, standard vector machines, etc. Okay. The original work that we did was with Lionel Tarasenko, and we were looking specifically at the static variables. In the study which we did with him in our step-down unit, we instrumented all the beds in a specific step-down unit, and all we measured was heart rate, respiratory rate, oxygen saturation, and whenever a blood pressure was measured, we had it. Using a training set of 200 patients, some of which became unstable and some of which did not, in which we told Dr. Tarasenko which ones were stable and unstable when they became there. And they then fed it into an algorithm. We were able to create a vital sign index. Shown on the top here is VSI. Now, what I'm showing you are the vital signs of a patient over 6 hours, which is not the way we normally look at vital signs. And as you can see, the heart rate varies a bit. It's the green one. The blue one is respiratory rate. SpO2 stays pretty good except for a couple of points, and blood pressure is wherever it is. If the vital sign index exceeded 3.2 for more than 15 minutes, a red alert came up. So as you can see, there were numerous red alerts shown here. Importantly, across the group of patients in this 2-week-long study, the mean time between the first time that VSI got red and therefore made an audible beep and a code being called on the patients because of insufficiency was 6.5 hours. This is important because one of the characteristics we see in critical illness is very, very few patients fall off a cliff. Almost all of them deteriorate over time, constantly rallying, but always failing as their health reserves do not work. Importantly, when the patients met code criteria by our institution, in the medical record, only 10 of them had a code call. Now, these were not shown to the nurses, so they didn't know what was happening, but their other devices were going beep just loud. Furthermore, if you look at this case, at these points right here during the case of a patient who's crashing at 1300 hours, at every single of those points there, 100% of the vital sign values were normal. So if you were to just look at the patient periodically, you would not be able to identify instability. So we took this approach with Marilyn Haravnik, which I showed you, which was our phase 1. We then opened up the screen in phase 3 and said to the nurses, okay, if the machine goes beep, you absolutely positively have to see the patient. But if there's something wrong, fix it. If you can't fix it, call a code. So we separated out all the times there was a medical emergency team activation, meaning the machine went beep, as all. If it was just a minimal thing that did not really require a code, but could have been by giving a bronchodilator, the nurse increasing oxygen, or putting a patient back on oxygen, giving them a pain medicine or something, we call that a MET-min. And then if they had a full-blown MET that you need to call a code, we called it a MET-full. So this was the results when we had blinded the nurses to the vital sign index. But when we showed it to them at the bedside and at the nursing station during phase 3, what we saw was we profoundly were able to decrease the progression of patients to MET-full. And the reason was everyone that got a MET-full progressed to it from a MET-min, and using the MET-min, we were able to decrease the patients who would further deteriorate. This is the fundamental proof of medicine, which is that treating a patient early requires less energy and less instability. We were able to, in this study with Dr. Haravnik, able to cut the total alarm times by greater than 50%. When we then look back at those same patients and said, when we were in phase 3 in which the vital sign index was being used, and we simply asked the question, how long were the patients in these conditions, you can see that we were able to markedly decrease the time they were in a MET-min. But when a patient deteriorated, once that had happened, the total time it took for us to treat the patient was unchanged. So the trick is to identify patients before they crash, not during the time that they crash. That's what's important. So if you think about it, we have a threshold value of stress. And let's assume I have a patient who is going to deteriorate for whatever reason, cardiovascular insufficiency because of ongoing sepsis, hemorrhage, COPD with retained secretions, ARDS, it doesn't matter. And as I showed you before, the deterioration of patients is not straight line. And in this example, I've just drawn a line that's curvy and going up. Where the level of stress actually becomes present is shown there. Our present clinical threshold level, meaning the level in which we say if the heart rate is greater than this, the O2 sat is less than that, whatever it is, I drew with this line. Theoretically, therefore, we should be able to identify all the patients at this point. I just showed you in our clinical study with step-down unit patients, we were too late in getting them. And we didn't get them at that point. But if we had, you would have treated the patient, they'd get better. That would be called nowcasting. So making smart alerts that identify accurately where you are without having artifacts is nowcasting. And that will be better than where we are even right now. But what we want to do is we want to look at those subliminal levels of threshold change, which are physically there. You just aren't identifying it because it just, well, they're a little bit heart rate up, but who cares? They're looking fine or they're a little anxious. But if you look at the overall picture, it actually says they are insecure. You can get them earlier and treat them before they deteriorate. That's forecasting. Okay. So we have the ability to triage and monitor. We can use high frequency data and low frequency data. The Apache scores and SAPs, that's high frequency data triage. And threshold alarms, like I just showed you, our vital sign indexes for monitoring. But what we want to be is we want to be out here in the future. We want to use high frequency data to prognose what's going to be done beforehand. Well, you never really can predict the future before it starts. If you could, we'd all be millionaires from going to the stock market. But you can assign probabilities based on the nature of surgery, the functional status, ASA score, et cetera, and then look at them more closely because the probability that they will deteriorate later is much higher. And thus, if you see subtle signs in them, it's important. So we can identify right now if patients are unstable using outcasting. But we should be able to identify those subliminal signatures that identify when a patient will subsequently be unstable, and that's forecasting. Let's start with the first problem. As you saw, we used an artificial neural net with just 3 nodes for our study that we published about, I guess it's 12 years ago now. And what we found was, to our surprise, that the vital sign index went beep an average of about 9.5 minutes before any one of the individual vital signs, heart rate, respiratory rate, O2 sat, blood pressure, was abnormal, because what it saw was a signature. And so we felt that this would allow us to identify instability before it happened. So the next level up is to look at the dynamic continuously monitoring variables using machine learning driven algorithms. And now we come back to the United States, and on the left of the screen is my good friend Artur Dobronsky, and on the right is one of my colleagues for many, many years, Gilles Clermont. They're the 2 people that are working with me very much on this. And what we're looking at are more featurization of the data than simply just a neural net. All of these things are just fancy statistical analysis substances, which the reason we call it machine learning is because the machine can run a whole lot of computational numbers much faster than we are, but it's not rocket science. It's really just using the data intelligently. Okay. So one of the first things that we wanted to do was to determine whether or not what was going on was appropriate in terms of orders being real time. And the problem with real-time data is it's really complex. So with Gilles Clermont, we looked at the electronic health record libraries, and we looked for patients whose orders were outside the range of normal. Let's say giving Lasix 150 milligrams first time in a person with a normal serum creatinine. This should probably put a red flag up for you. And what they were able to do in the initial study was to generate alerts that said, this is a mistake. And what they found when they looked at the records and went back retrospectively is that the number of times when the order was done and it fell out of the normal level, it turned out to be correct 25 to 60% of the time. Now, you're all doctors, and you know that if you usually give a drug or a treatment within a specific situation, which may not be exactly covered in a classic textbook, but it's the right thing to do at the bedside. So using alerts that are non-specific and don't have the contextualness of the patient can cause errors by having too many alerts. When we tried to do this in a larger group of patients, we weren't much better in trying to improve the performance. So what we had to do is identify when was an alert appropriate and when was it really inappropriate, which we're going to call artifacts. The problem we have presently is that when you go into any intensive care unit or step-down unit, you hear a bunch of alarms going off. This has often been called the acoustic wallpaper of the ICU. And because of this, there's alarm fatigue. The alarms go off, the nurses could care less what it is because it bothers them. And this creates problems because if it's a real alarm, they don't see it in time, and this can be a reason for failure to rescue. So using a simple artificial neural net, we decided to figure out if we could describe them. Didn't work out too well. So we had to do a decision tree analysis in which we put everything in a random forest in terms of what was going on. A bunch of trees at random is a random forest. And what we were able to do then was to characterize whether or not the alert that came out was real or artifact. And what we simply asked the question is, if we were measuring SpO2, respiratory rate, or heart rate alerts, Can we discriminate real from artifact in real time on the fly to filter out as many artifacts as we can so that when you hear a beep, it's real and you should act on it? So in collaboration with Karen Shen a few years ago, we modeled these various types of artifacts, which we gave it to her in a semi-supervised version, meaning we said, this is clearly an artifact. And then she said, fine, this is what I'll do. And we use various things like looking about how are you right now relative to everyone you know, that's K nearest neighbor. How do you all work relative to what you thought was around, that's logistic regression. And you can go on with the different types of assessments. And what we were able to do using this very simple concept was to markedly reduce the number of artifacts in real time, such that when the machine went beep, there was very little chance that it was wrong. And if you looked at the area under the curve of the receiver operator characteristics that said we were doing it right, and on the bottom of this graph for respiratory rate, blood pressure, and SpO2, you can see the various types of tests that we used. And for respiratory rate, it's very clear. It doesn't matter which one of the fancy machine learning tests that you use. They all are pretty good at predicting what goes on. But interestingly, for blood pressure and SpO2, you have to use K nearest neighbors and natural Bayesian because they tend to work out better than other things like random forest to identify artifact. So at the present time, we have created a real-time artifact filter that allows you to go into your data in real time, filter out the noise, and be able to manage those patients. So, showed this before. So, what sort of machine learning alerts can I give you? Well, the easiest one to do, which was our vital sign index, was simply to say, are you sick? It goes off when the data is significantly above an envelope of what you expect. The next one you can do is they're sick, but what's wrong? This says they're sick, but this is hypovolemia. This is cardiac dysfunction. This is chronic obstructive lung disease, unable to breathe. It classifies the level of sickness. It's a further level of sophistication of the alert. Then we can say, are they getting better? Are they getting worse? Because I can say that you've got cardiovascular insufficiency associated with hypovolemia and it's getting worse. And then they give you fluids and they say, it's getting better. And that shows you that you not only identified what was wrong, that they were sick, what was making it, but you could then track response to treatment. And all of these things can be done at various levels of extraction, raw data, featurization, et cetera. So with Karen Shen, a few years ago, we went back to our step-down unit data and we created a model in which we asked the question, when patients come into the step-down unit and we look at them, when they come in, we wait, we don't use the first 15 minutes of time they're there simply because during that first 15 minutes, they're being transferred over to the bed from the stretcher. They come from the emergency room, from the operating room, from the floor. And the step-down unit is mainly trauma and surgery patients. So after the first 15 minutes, we then say, we'll take the next 15 minutes of continuous data and we'll featurize patients who will subsequently crash, here shown in red, or would subsequently not crash. And then we tested this on a second group of patients that weren't used to create the model. And that's the data we're showing you here. So as you can see, if you look at patients for the first 4 hours that they're in a step-down unit, you can see that those patients who will subsequently crash in the next 2 days completely separate out under most conditions immediately when you see them. This is triage. If you went and looked at when they did crash, and of course their crashing here is 0, this is when they're stable, you can see it is going up further. But the problem is they were already unstable. So how do you know when to jump in to take care of the patient? This would be about 190 minutes, but the alarm was already going off. Importantly, and we actually did not try to do this, it just turned out that we are very, very good at defining stability in our patients. In 80% of the population of patients who never crashed for the first 2 days they were in the step-down unit, we could predict with 1 in 1,000, 10,000 errors. So that means that I would say in 999 patients out of 1,000, they aren't going to crash, and I would be right. That's phenomenally good for triage. But how can I use that same data to identify when they're actually going to crash? Because yeah, I might say, you're going to die. But then again, regrettably, I could say to everyone who's listening to this podcast, you're all going to die. I just don't know when. Wouldn't you like to know when that person who has a higher risk, when they will die? So what we did is we forced the data for both the group that would die and the group that wouldn't into that being their baseline normal. So let's assume it's an interstitial fibrosis patient and the respiratory rate is 30 breaths a minute. You say, fine, that's where they live. We're not calling that abnormal. And then we followed their normalized data when they crashed. And as you can see, there was a clear, sharp separation of those patients at least 1 hour beforehand. And that's well within the time it takes to mobilize people to come to the bedside. And that's forecasting. We weren't as good at this as we were with predicting stability, but in 60% of the patients, we could identify within 1 in 1,000, 10,000 again, 90 minutes ahead of time. Okay, and that's really forecasting. Furthermore, and this is really neat, we asked a question. This is called latent group analysis. I think you've seen it in ARDS patients where they talk about the primary ARDS and secondary ARDS, and they have different physiologic phenotypes in response to treatment. Well, when we looked at our own patients in our step-down unit, we discovered 5 levels of instability compared to the black line, which was the patients who never crashed. In groups 5, 3, and 1, 2 and 1, the patients crashed at the end. But 5, they were sick from the beginning, and you knew they were going to crash. You just had to follow them. Interestingly, the group 3, they started crashing 2 hours beforehand. But in all cases, we could identify everyone within at least 15 minutes. What you're looking at here is what disease looks like. Nobody crashes per se, but on their own. We all have adaptive physiologic mechanisms to maintain gas exchange, ventilation, blood flow that are sympathetically mediated, plus ways of getting vascular refill to maintain blood volume if you're hemorrhagic. And therefore, we all follow general pathways when we are deteriorating, whether we like it or not, based on the primary etiology of what's going on. We took this same approach to look at over 500 patients who had COVID-19 from Columbia University in a study we published, I guess that's 2 years ago now. And what we found was the exact same thing. There were essentially 4 totally different groups of patients. The ones that had group endotype 3 and 4 on the bottom, you can see their cumulative survival was very low. But the groups on the top, group 1 and 2, had a great survival. Now, I'm a really good fan of group 2 because group 2 patients were elderly people without comorbidities. And before this was done, we thought that elderly people were at risk specifically for dying of COVID. It's not elderly that makes it, it's the comorbidities that gives the mortality. And that was why this was an important paper. And if you're ever going to see studies that look at machine learning approaches, they have to have either a figure or a table like this that says, what were the drivers? What were the physiologic variables that created the various endogroups that made them look different from each other? There has to be a clinical relevance. It has to make sense to you that you're seeing data that, okay, that makes sense. The patients in group 3 and 4 were intubated more, but they also had more inflammatory markers, okay? That's the important points. And so whenever you see in machine learning, you don't want to say, the system works, trust me. That's wrong. You have to show that it works well. So to look at this in a little bit more academic way, we went into the animal model and we used Juan Carlos Poyona from Columbia's hemorrhagic shock model that we've had in our lab now for about 15 years. Hernando Gomez, who's one of our leaders in the group now, is now leading this. And Zinker, Jan Zinker, who's back in Germany, is a machine learning guru who's working with us on it. All we're going to be focusing on in this model is as we bled them down to a very low blood pressure, and we then waited, we're going to ask the question, can we identify when the animal starts bleeding? To do this, we look at personal components analysis, and that is to take features of them, of the patient's measured variables, and determine which are the ones that are most relevant. In this picture here, we're showing for different colors or different animals, the principal components of two of the variables that we're changing. On the line below is the timeline, and the blue point is when hemorrhage starts. So let's see this. At the very beginning, you can see that the animals are profoundly different in these two principal components. But as they progress with stress, you can see how, in fact, their signatures are becoming identical. And this makes sense clinically. It's very hard to control patients with hypertension, essential hypertension, with the exact same drugs because patients have extremely different varied responses. But when they're critically ill in the intensive care unit, we can often use the exact same treatments in all patients because they have lost their compensation up in that point. So we were able in our hemorrhagic shock model to be able to identify, and this is in all the pigs, when the pigs were going to bleed based on an anomaly. Remember, sick, yes or no? Well, this was an anomaly detector. When it was greater than the 50% that they were abnormal, you can see that we are able to identify instability. And this is all the pigs for a specific bleeding rate of 20 mLs per minute. At this point right here, we could identify with a high degree of accuracy that every one of these pigs was bleeding. And this is only 7 minutes into it. And at 7 minutes into the bleed, there was absolutely no measured change in any of the variables that I could see. The heart rate wasn't different, the CVP, the blood pressure, nothing was changed. Yet by looking at the featurization of all of the invasive monitoring and using a machine learning technique, just random forest, to look at those features, you can see that we can identify it. There's where the bleed is. That's how much closer we can make it. Furthermore, several of the animals were bled at different rates. The red line represents a bleeding rate of 20 mLs a minute, and this is the anomaly detector for that. And you can see that compared to an animal bled at 5 mLs a minute, the rate went up. Green is baseline. So what you can see here is that I can not only tell you that the animals are bleeding, but on a regression analysis, I can tell you how fast are they bleeding. And if you gave fluids at 15 mLs per minute to the 20 ml per minute bleeding pigs, they would look like 5 ml per minute pigs. So you could actually look at the rate of bleeding even if you resuscitated them. Interestingly, that anomaly detection, as was shown here in a study that we did with Artur Dobronsky, you can see that we looked at with the progressive bleed, this is the hemorrhage, this blue. Probably should have been written in red, but that's another story. As you can see, as we gave bleeding, we got progressively higher anomaly. Now, at this point in time, we resuscitate. Oops, I'm sorry. And the initial improvement in resuscitation was due to the fluid. But at this point in time, they were no longer volume responsive, and we started norepinephrine. And the actual improvement in the anomaly down to normal occurred independent of treating the primary cause of the shock, which was hemorrhage. By giving norepinephrine, we could also improve it. And so what this says is the anomaly detection isn't looking at the cause, it is looking at the response. And if you can show the response has gone away, then you'll be able to see that too. We asked another question, and that was simply, what is the value of looking at featurization of various variables? CVP, mean arterial pressure, P8 pressures, pulse oximeter, O2 sats. We're looking at them all together, and we assessed it using an activity monitoring curve, an AMOC curve, in which you ask the question, what are the trade-offs between the time that you could detect bleeding, which would be 0, and having false positives. Well, if you want to never have an error of having a false negative, so every time the machine, if the patient is going to be unstable, the machine goes beep. But you don't care if the patient's stable and the machine goes beep. You just don't want to miss one. Well, you should have the alarm on all the time, because eventually it'll be right. That's going to be a very high false positive rate of all the time. What you really want to do is trade off only having false positive every 30 minutes, every 300 minutes. And if you use fuse parameters, you can see that we could identify that bleeding was definitely occurring at being only wrong 1 in 300 at 75 minutes within bleeding if we used multiple parameters. This means that the more independent variables you use to featureize cardiovascular and respiratory sufficiency, the more specific you can be at determining that there is instability present. Furthermore, the rate of sampling, do you measure beat to beat every 15 seconds, every 5 minutes, every hour? Okay, if you measure, if you go to a doctor for your annual checkup, you're being assessed every year. That's not going to work very well if you have trauma. So as you can see here, if we were to look at what happens with every 5 minutes and then go to every 20 seconds or beat to beat, we progressively improve our ability to identify instability earlier. So it costs money, sampling power, to sample things beat to beat and waveform. But if you do and you need it, it improves that data. Furthermore, in another study we did, we asked the question, what sort of monitoring do I need to do to improve the lowest false positive rate to time of detection? If you use non-invasive monitoring or central venous catheter, you might as well go home. But as you can see, using things like the arterial catheter plus CVP or pulmonary artery catheter, they were markedly better. Looking at receiver operator characteristics in which you plot the false negatives or false positives on the log of the false positive rate or false negative rate with the line that you're familiar with, which would be the straight line across sensitivity and specificity. Now that the log scale goes down like this, you can see that I can really identify when performance improves. And based on this, it is absolutely clear that if you have an arterial catheter plus a CVP or a pulmonary artery catheter, the featurization of those data is excellent. Since the surviving sepsis guidelines suggest that in a patient who doesn't respond with fluids initially to hypotension needs to have an arterial catheter placed, this gives you the rationale to be able to featurize those data. As you can see, featurization improves with the advanced monitoring, and they have a better response. Finally, we can normalize the data. Here is the central venous pressure from our pig model, and you can see at this point here, they're crashing, but it's hard to look at. If you simply normalize them to say, I don't care what the CVP is, where it's normal for them, and look at its proportional change, you can see how much more accurately you can now see the trending goes on. So if I know your baseline value, I can markedly improve outcome. And that is exactly what we showed with Anthony Wirtz. If you looked at the intermittent data without baseline, it was no different than having individual variables. And that was also true for beat to beat if you did not have a baseline. But if you had a baseline, those values markedly improve performance. Importantly, look at the red dotted line. The red dotted line is the ability to predict instability when you did not know the baseline. So if you do not know the baseline, you want the most intense data you can, featurization on the waveforms, because that's the only way you'll identify it. So what did we learn from our basic animal models? The multivariate models are good. We can characterize instability. There are trade-offs with invasiveness for more information, and then personalization is very promising. So based on that, we now know that if you increase the sample frequency and you do observations beforehand for at least 20 seconds, Based on the data you're already getting, we can identify instability. Performance is defined by a true positive rate and false and true negative rate, because you don't want to have false alarms, but you also don't want to miss real events. Last point that I'm going to talk to before I show you some data on patients is we need to standardize the ways in which we collect data across hospital systems and in everything that we do. And indeed, this was the basis of a position paper that we wrote as a group of people, critical care doctors who were also in machine learning. And by the way, the CMU people were also on this from our group, were also authors on this paper. And based on this, the National Science Foundation and the NIH has founded a group called CHORUS to harmonize the quality and the way we report all data in ICUs. This has just started, and Dr. Gilles Clermont from our group is leading it, but this was the initiation. Okay, got it. So as you saw with the lessons learned, single variables are not good at predicting what happens. They have a very poor response rate. When you do multiple variables, you can actually class not only identify there's instability, but look at the trending over time to see the severity of in this case, bleeding, and that there are trade-offs. The more invasive you make the monitoring and the higher the level of invasivity, the more accurate you are, but this also requires that you put in an arterial catheter or a PA catheter. And I don't think anyone in this room would voluntarily let me put an arterial catheter in them for no reason. And finally, if I know your personal data, then I can tell you very accurately if you're deteriorating. This is useful if you're dealing with patients who are going into surgery because you have them in the immediate pre-op period. And remember, you only need 15 minutes of baseline to be able to get a strong definition. So pre-op, this is perfect. So now let's talk about hemodynamic monitoring parsimony. What this means is we need to take the minimal amount of data that's possible because it's expensive, time-wise, and storage and processing. So what is the minimal independent variables I want? Heart rate, blood pressure, O2 sat, pulse oximeter, plethysmograph, it doesn't matter. And what is the sampling frequency? Can I get away with every 4 hours? For slow things, probably yes. But for rapidly changing cardiorespiratory issues, the answer is no. I need to be beat to beat or waveform. Waveform if I don't know their baseline. And the observation period, how long do I need to look at them before I know what's going to happen? If I look at you for 1 second, I know where you are at that moment, but I don't know where you're going. So you need a certain duration of time for that trajectory. The minimal amount is going to be for most people about 2 minutes, but you can get away with 20 seconds, okay? We define performance as a positive and negative predictive value. You want to be able to say for sure someone is going to crash or are crashing, or for sure they are not. You don't want to say they're crashing when they're not, and you don't want to say they're fine when they're falling over dead, okay? So based on this, a few years ago, we presented a position paper across the United States, and this is the reference, that said we needed to create a uniform data structure across all hospitals and healthcare systems in which the data is put into the same matrix so that people can analyze it across different centers. This is the basis that the NIH and the National Science Foundation came in to funding a 19 hospital center consortium called CHORUS, which will be trying to harmonize it across the 19 major medical centers. And the lead center for this, I'm very proud, is the University of Pittsburgh and Gilles Clermont from our group. Now let's look at data in terms of predicting instability in the ICU. The first thing we wanted to do is if we could identify relevant tachycardia. Well, what's tachycardia? Well, it's a fast heart rate, but who cares? It has to have some clinical relevance. So we simply looked at the data from patients in the MIMIC database and said, if your heart rate was 110, 120, 130, or none, what was your use of norepinephrine, ICU stay, or ICU mortality. And it was absolutely clear that across all the metrics, the most relevant tachycardia was that where the heart rate was over 130. Yes, it's not good to be 110 or 120 for other reasons, but there was a clear step up in mortality. So we decided to use 130. Well, what is 130? 130 beats per minute can be just for a quick second, as you can see up in the top line, or it can be, for example, atrial fibrillation in the bottom, which is sustained. So we defined tachycardia as a duration of at least 10 minutes at a heart rate of greater than the threshold value over a 20-minute window. So you can be a little bit up, a little bit up, a little bit, but over 20 minutes, it's greater than 10 minutes, and that counts. So using those data, we featurized patients against a group that didn't have tachycardia and compared it again to another group that weren't used for creating the model. And like I said at the beginning of my lecture, when you are shown featurization data, you need to be able to say, what did those people use to determine the features they use, and do they make sense to me? So if you want to identify when you're going to identify tachycardia at time 0, 10, 20, and 30 minutes beforehand, you can see the featurizations were basically of heart rate variables. Sometimes it was arterial blood pressure means, et cetera, but these were primarily featurizations of heart rate that come into the concept of apparent entropy. What we found is to identify any tachycardia. Here, the tachycardia cases are in blue and the controls are in red. You can see that we could clearly separate them out well in advance. But what you really care about is not a patient has recurrent tachycardia. You really care about the first event of tachycardia, because once they've had the first event, you know they're tachycardic and you worry about them. And as you can see in this example, we can significantly separate out patients who were going to become tachycardic versus that wouldn't 75 minutes beforehand, using the features I showed you in the previous slide. We then went ahead and said, okay, let's now determine if we can define clinically relevant hypotension, which was a mean arterial pressure of less than 65 for more than 5 minutes in any 10-minute interval. And once again, here, those patients who will become unstable is a solid red line, and those patients who never became unstable is blue. And the dotted lines are simply the total number of subjects that we used in the data sets. And you can see they were up to 800 to 1,000 patients in each set. So it was a very large group. What we found is we were better at separating out no hypotension from eventual hypotension. And there was a clear separation out of the patients 60 minutes beforehand. Now, you may be aware of the Edwards Hypotension Prediction Index that gives you a clear separation about 10 minutes beforehand in the operating room. The reason they're not any better is they only use the arterial pressure waveform to determine hypotension. We use all available hemodynamic data, and if you group multiple data, you can be more specific. And just like I showed you for the heart rate tachycardia, these were the features that we needed to predict hypotension in our patients in the ICU. And they happen to be blood pressure measurements, sometimes mean pressure, sometimes systolic pressure. And these were the most predictive for us. And we didn't choose them. The machine learning algorithm chose them. Okay. I showed that already. So in the future, this is finishing up. We're going to monitor the monitors, but treat the patients. We have now and will be able to apply in real time robust artifact detection, which means that if it's an artifact, the machine will not go beep. It's bad. It'll go beep that you're not getting good data to make a decision. It'll be a separate type of a beep. And it should therefore decrease alarm fatigue, but allow you to, on the fly, do real-time analysis of those data to predict instability using fuse parameters, which would be those that are featurized, not what is the heart rate greater than 110. It's when are all these things getting bad that the patient's going to crash. And we will be able to scale these things using different variables once we make this possible. And so the major errors now are getting the data in real time in the pipelines. One of the ways we propose to do it is to use an intelligent clinical decision support system, which we call IQ. And it's a force multiplication because you can use it to identify when instability is present or not, and requires less qualified staff because all they have to do is hear a beep and then they know to call you. It's excellent for disaster medicine and pandemics. And it uses the standard of care because what you're doing is you're simplifying the resource use. And it's modifiable over time because this is just an algorithm. So let me show you our existing algorithm, and this is the next to the last slide, that we've developed over the last few years. We call it Predicting Instability Time and Treatment, PIT. And it took us a long time to figure out how to make the abbreviation PIT for the University of Pittsburgh. And so what you have on the top is the probability of an event. 100% would be on the left and 0 be on the right. And the second is the event horizon on the bottom. Is this going to happen the next 10 minutes, 5 minutes, or an hour from now? And then on the bottom, you have your usual vital signs from a monitor shown here. But below it, you have the equivalent of the vital sign index, which is a fuse parameter showing you over time how all of these variables that are present, which you're seeing here in real time what their values are giving you the feature. And at this point here, you're predicting what's going to happen over the next time. And in this example here of a real human being, it predicts that in the next 8 minutes, the oxygen saturation is going to fall to a critical level, okay? And on the other side here, this is a pie diagram that says of the event that's happening, how much of it was due to loss of vasomotor tone, loss of effective circulating volume, or impaired ventricular pump function. So when you identify that there's something wrong with a patient and you treat them, the probability that the event will occur will decrease. And as you treat them effectively, the time that it'll happen, you'll run away from instability. And that is our goal. So to summarize, I want to thank you for listening to this. The research I showed was not done by me, but by all my co-investigators with my input. I just am the director. At the University of Pittsburgh is Gilles Clermont and Marilyn Hrabnik that did most of it. And at Carnegie Mellon University, it's Arthur Dobronsky and the amazing people in his lab, the Auton lab at CMU. And between us all, we were able to do this as a partnership. And with that, I thank you for your attention. Okay, glad to answer questions.
Thank you, Professor. Only one word comes to my mind, and it's genius. Really incredible data that you just shown. And I've got a lot of questions, not a lot, but because not many people can ask many questions on this subject since it's so advanced. One of the questions is that how can you manage big data? I mean, if you're going to try to have any prediction algorithms out of certain data, you need the data to let's say fall in the same time, the blood pressure, the EEG, the respiratory rate. How do you manage
that was the basis for that paper by Laird et al. Okay, which we said we need to have a standardization of multi-parameter, multi-scale. Some things you measure every 2 hours. Some things you measure at this moment, but you only get the result an hour later, like electrolytes. Okay. The information was relevant an hour ago, but you hear it now. So you need to have the ability to have an adjusting matrix of data that as you backfill data that's coming later from when it was originally done, you say, okay, this is part of the image I had before, and then you look at it different than the way you are now. At the present time, what you, Carlos, and I do is you take the data, let's say, of the potassium that you get right now from what you did an hour ago, and you assume it's the potassium right now. And it isn't. It was a potassium an hour ago.
Exactly.
And so and you probably have given things between then and now, and it might be quite different. So the point is that you need to have these multi-dimensional, meaning some things are fast, some things are slow, multi-parameter variables into a matrix that allow you to look at it together. This is beyond my expertise to create, but it's not at all difficult to do because we have done this already. Every single medical center that's doing machine learning, whether it's University of Pittsburgh, MIT, Harvard, University of California, San Francisco, University of Chicago, Northwestern, and UCLA, every one of them created a relational database that allowed them to look at their own data themselves. And they could do it retrospectively, easily. The hard part is doing it in real time. And we have been spending the last 3 years getting our data linked in real time, because you can do anything retrospectively and create wonderful models. It's applying them in real time that requires that input. And we just had a meeting about this last week. And in that meeting, we came to the summary that we can get about a 4 to 5 minute delay of having the models being accurate in real time in the ICU. Okay, which is better than anything that's out there now. And it's probably about as good as you'll get, because it takes a certain time to accommodate the data and the run, because you're running maybe 30 or 40 algorithms on the same data.
Yeah.
And even if it's a computer, it takes time.
Yeah. The next question is that, of course, when you're using multiple variables in time and you're comparing this, there is always a room for error. So do you try to compensate for this error, like using the Benjamin E. Hochberg or any other statistical test to reduce the bias or the error by comparing multiple? This is millions of data, I guess. This is millions of heart rates and millions of systolic blood pressures.
Gotcha. Okay. So it became painfully clear years ago that the only way that you could identify what was normal or abnormal in one person was to have thousands of other patients that were normal and abnormal that looked just like them, that you could then follow over time using, for example, a k-nearest neighbor. We have therefore 12 years ago set up and are now continuously recording waveform data linked to the electronic health record of all our ICU patients. That's my NIH grants. The hospital, by the way, isn't paying for any of it. And I'm paying for all of it. And it took us about 5 years of that before we even had enough data to do modeling. So our initial work was all in animals, because I had the data in animals that we could look at. So that's why those papers came out. But we now have, as you saw, enough data in humans where we can look at what is okay, if I need 500 human beings that are female, age 37, who have diabetes, to see what happens to them when they get insulin. And then when you come into 37 female DKA and you need insulin, I can tell you exactly what your trajectory is going to be, no matter what it is, because I've got all these other people that were just like you. Okay. So you need big data to assess what somebody is like if you don't know what they were like before. Now, as a doctor, the opposite is also true. If you know a patient, you say, this patient likes a wedge pressure of 20, This patient likes a mean arterial pressure of 80 because their urine output is great. And if you have it at 60, it isn't. There's no algorithm I can write will be better than your personal observation of the personal response of that patient. So the other thing the algorithms do is they learn what you are doing. So they get better over time, but over a very short interval of time as they watch what's going on. So over a period of 15 minutes with active resuscitation, we can be much more accurately aware of the stability, robustness, and reserve of a patient than we would be when we first saw them. But as an ICU doctor, you're the same, right? I feel much more comfortable 30 minutes into a resuscitation of a patient who was crashing and everything was terrible, independent of the fact they got the norepinephrine on and they've got some fluid. Okay, because I now understand how they respond to what I'm giving them, and I can now titrate the care to that. That's not in the textbook. That's from seeing the patient. So the way we do that clinically is we look at a large database of a whole bunch of patients to predict what we'll see. But then if we know the patient, we say that might be true for everyone, but there's a subtle difference in this patient, which modifies the coefficients by 0.2 or something. And then what you're doing is not just precise resuscitation, you're doing personalized precise resuscitation.
Exactly.
And that's the goal of our work. As a matter of fact, that's the title of our grant, Personalized Precise Resuscitation.
Great, excellent. What about other variables that the eye cannot see? Because you can see the heart rate, you can see the systolic blood pressure, but what about the angle of the QRS or the
Of course,
area under the
of course,
keloid?
that is 100% that's what featurization means. When we talk about featurization, what you say is I'm getting a waveform data, and I have absolutely no idea what aspects of that waveform I'm going to need to use. For example, we were able to show years ago and published it in our animal model that although CVP, mean value, and the change in CVP could not in any way predict if an animal was hemorrhaging. Okay. Now later on, when they're next to death, the CVP will be low. But during the time that you want to do something about it, it was useless. But what the featurization told us was that if you looked at the difference in the waveform shape between inspiration and expiration during positive pressure ventilation, and specifically the Y descent was lost in inspiration, because that's when you have decreased venous return with the positive. The loss of the Y descent was profoundly sensitive. It decreases in effective circulating blood volume, whether due to giving vasodilate like nitroglycerin, or loss of sympathetic tone, or whatever. So we didn't know this. The featurizations told us. And we look, but this is where you have to be a doctor and not a computer scientist. You look at this data and you say, does this make physiologic sense? If it doesn't, then probably it's a phenomena that's unrelated to it. They're just measuring it as this thing. Okay. So that's the other part. I didn't get into at all the concept of fairness and bias. That is an entirely separate issue. And that is that your models be only as good as the training sets that you put them on. So if you do not have a whole bunch of elderly people, or you don't have a whole bunch of young people in it, and you're treating young people, the model won't be accurate.
Exactly.
Okay.
So it has to choose from which data to use.
Yes. And so this is why in our grants now, we have one of our major grants. We have Emory, which is Atlanta. They have a large Black population. UCLA, which has a large Hispanic population, and Pittsburgh, which has a lot of Polacks. And so between all of us, we have a nice melange of patients. So we create models in Pittsburgh, we run them in UCLA or Emory and say, where are they not working right? And then they take their models from their data and they run them on our data. And that's called federated learning. And when in between all of us, we create what is the best fuse parameter. But then, by the way, the one model will not work the same on everyone, because you usually know who the patient is you're treating. You rarely see a patient that you've never seen before and they're behind a screen and there's nobody there. Okay. So if I tell you this is a male of a certain genetic characteristic, and height, weight, et cetera, BMI, things like that, then the models will be different for that person than it would be for somebody else. Okay. Even if it's the same model, because those features that are the demographic features, which we say have a frequency variability of 0, because unless we're talking over a significant amount of time, your sex doesn't change. Your age only changes per minute going forward. You don't get younger. So there's all the demographic data determines characteristics of you which are fixed. So everyone gets their own fixed variables associated with the other variables that are coming in. And then if you say, oh, by the way, this person has chronic essential hypertension, which is very common, 30% of the population has it. They're a smoker or whatever. These are all modifying features. And those are integral to the models. And that's why you have to have not only the waveform data, but as I showed in my slides, linked to the electronic health record. Because we got the information there, we just have to use it. And once again, Carlos, this is not rocket science.
It's just modeling.
It's just modeling. If it doesn't make sense to you when I show you something, then it probably isn't true.
Yeah, exactly. That is what I tell all my residents. It has to make sense. And last question, Professor, is the PET available for selling or for using elsewhere?
Oh, we're not selling it. Of course not. It's free, but no, it hasn't been created at a good enough level. That will hopefully happen in the next 2 or 3 years as part of Chorus. As the Chorus is that 19 medical center consortium funded by the NIH and the National Science Foundation that Gilles Clermont is leading. Okay, and it will then be implementing these various graphic user interfaces that allow you to run the algorithms. The algorithms are not useful if they're not put into a format that allows you to make it operational at the bedside in real time. Okay, and so I showed you the PIT, which was simply an operational real-time system. Okay, that's what we have. And so for it to be usable for you, the biggest problem isn't the algorithm. The biggest problem is your data flow. You have to have the ability to have the data from your monitors placed into a repository in real time that's already linked to your electronic health record, which is not a problem because that's kind of slow, so that it can create real-time models that can be running continuously. So the real issue is not us building models. The real issue is you creating your own data flow system in your ICUs to allow that linked electronic record to feed back to you. But we can, if those things are done, we can feed these things back to you within 4 minutes. I showed you the study from Marilyn Ravnik using the vital sign index in the ICU in the step-down unit. Remember the first thing I showed?
Yep.
We went into the step-down unit and we wired every single step-down unit bed, pulled them into a central monitor, had a bedside monitor and a nursing station monitor for all of them, and we ran that. And so it didn't go anywhere else. It just stayed right there. The hospital wouldn't have paid for it. The company that had it, Oxford Vital Signs, was the one that paid for us to do it. But when we did it, it worked amazingly well. Hospitals are not set up at the present time to allow their data to be run. New hospitals tend to have this available, but old hospitals don't. You don't have the fibers running between the units, et cetera, going to a data warehouse that allows it to be used. But if you did, you'd then have what's called a smart hospital. And smart hospitals are the future.
Exactly. Well, Professor, I want to thank you for your excellent presentation. Amazing, as usual. And I hope to see you again very soon.
Okay. Take care, Carlos. And thank you to you and your students for listening to me.
Thank you.
Bye-bye.
Bye-bye.